We'll move on to our next speaker, who is Dr. Mario Goessl, who will talk to us about getting started in LAA closure therapy and what are the logistics and challenges of starting a program. Thank you. Mario.
Thank you very much for the invitation. Can I just ask for a show of hands, who is about to start a Watchman program or in the early phases of a Watchman program? Well, that's good. Because I was thinking I'm talking to all these experts now, and that's not even interesting anymore. All right, good. So I'm going to share my first experiences in restarting a program. We were part of the trials, but then I thought that's an easy task to start the program again because we already did it, and it wasn't that easy actually. So I start with the first slide, cost and reimbursement, and I see David Holmes over there because that was one of my first questions to him. I emailed him a couple of times. Obviously, every institution has an upfront investment, which is quite significant. And then if you have a lot of Medicare patients, you're probably okay. But what I experienced, is, especially in our area, which might be unique, but some of our Part B payers actually do not want to pay for this procedure. So if that's something you have to explore, you should probably do this quite early. It's interesting because obviously the group around David really got everything started. There's a registry, there's the FDA approval, and there's still Part B payers who constantly say that this is an investigational device, so they're unwilling to pay for the procedure. That's interesting also because if you think about data that are coming out, this is one of the publications here in the European Heart Journal in 2016, it seems that there's actually also a cost benefit if we're using Watchman devices in patients with atrial fibrillation. So I wish that all the insurers at some point pick this up. And an additional comment I want to make there, because I don't have it on the slide, is if you have a team around you that is asking for pre-authorization, so all your business office people, they really need to know the specifics about the reimbursement of this device, because you might run into trouble that one or two people don't quite know, and then the pre-authorization doesn't work out, and it turns out it was just a business office problem. So that was one of the experiences that we had too. And then obviously there's criteria that we all have to follow, and they're highlighted here, and there's a few that I really wanted to highlight. So first of all, of course, you have to have some sort of documentation of these criteria. First of all, you should do a CHA2DS2-VASc score. Obviously, it has to be more than 3 or equal to 3. And then there's this sentence here. They have to be suitable for short-term warfarin therapy, which is 4 to 5 days. And there's this shared decision between an independent physician that doesn't do the implant. So you have to set up your office and your practice that way. The whole warfarin issue obviously is, it's formulated in a way that you say they have to have a reasonable, you have to look for an alternative to warfarin therapy. And that's of course a very wide term, and I hope we can get to that at some point, and what would be interesting to see what other institutions do. Now, the inclusion or exclusion is unable to take a long-term oral anticoagulant, right? So when we restarted the program, the problem was that I got all these phone calls from people who basically told me, well, I have this patient who basically, when they look at the warfarin prescription, they already bleed, right? Can you please help this patient? Well, and then, well, I can, but do I have to? I mean, at this point, I cannot, right? If I really follow the CMS criteria, then they have to be on warfarin for 45 days. But if you look at institutions around you, you might get the experience that people actually omit the 45 days of warfarin. So I think that's certainly a problem that hopefully is resolved by you guys soon here with your trials. Then they have, I think, a good inclusion is frequent falls on warfarin therapy. I think that happens quite a bit. I think I find that a good one. But then there's this one. I'm fed up with taking oral anticoagulation, and it happens quite a bit. So it's one of the other phone calls I get where a patient is seeking an alternative because they don't want to afford a NOAC, but they also don't want to take warfarin. But again, is that really covered by all the inclusion-exclusion criteria? I would say that's definitely not. And there's other side effects which are interesting. Some people really claim that under warfarin and NOAC therapy, they have all kinds of weird side effects, but can I really include that as a reasonable alternative? So then the next thing that I asked David and others is, okay, what do you guys actually define non-valvular atrial fibrillation? Because guidelines versus common practice or sense, and what do I do with that? Do I include mitral regurgitation, bioprosthesis, the rings, any valve disease? So then my EP colleague said, well, we're going to follow, of course, the HRS guidelines, and they are shared with AJ and ACC. And here's the guideline. It's AFIB in the absence of rheumatic mitral stenosis, a mechanical or bioprosthetic heart valve, or repair. Okay, I mean, if you have already started a program or you're about to start, many patients will have or fall into this criteria. So if you take this very strictly, you might run into an issue with including patients in your practice. Now, this is just one example here, but European are a little bit more straightforward there, and they came up with this MARM-AF wording or acronym here, which I think I like. And I think it's going into practice more and more. I see that one of the TAVR Watchman trials actually is including this more than the actual HRS guidelines. And I think it makes sense. If you read this paper, it's quite interesting how they justify their argumentation, because they basically go from a mechanistic or physiological standpoint and say it's not all the same, right? Mitral valve regurgitation, AFib, and mitral stenosis, AFib. The reasoning behind anticoagulation is probably different. So I think this is up for discussion. So should we say non-AFib or non-valvular atrial fibrillation, is this just mechanical, and the real rheumatic valve disease moderate to severe stenosis? So it would be interesting to hear what other people think. So this would be my proposal. Maybe we can change that somehow. Get the word out. So it reminded me of starting a program with TAVR or MitraClip elsewhere. You need to really give talks to your local providers. It depends on how you set up, but if you're set up in a way that you have many referring groups, you need to go out and give 5-10-minute talks again, because it's just reinformation. People have other things to do. They don't remember what the Watchman was, and they don't remember what the inclusion criteria is. So they need to know about the Watchman, but also that you are the one who is implanting it. Update everyone, not only your referring people. So your nurses in your hospital, your PAs, schedulers, physicians, in and outpatient physicians, they really all need to know that you're doing it again. It's kind of interesting. Again, we were a participant in the trials, and it was completely forgotten after a year. Definitely send reminders, and then repeat everything again, because it's very important. Gather your team. Some of my last slides here. You have to have a coordinator. If you don't have a coordinator, I would be surprised that your program works. There needs to be someone really completely involved in what you do. They need to recheck those patients, call them, call the schedulers, call the business offices. Otherwise, you're going to be too busy creating this. I would suggest that you need another IC or EP colleague. I think that always works better, especially in private practice groups. And I would also suggest do 25 to 50 procedures together so that you have some combined experience in the beginning. And then, of course, involve your PAs and APs. I think that's also very worthwhile for post and pre-op orders. Very important, and Richard is sitting here with his team. You need a good TEE echocardiologist, and I think it's appropriately so that we call them now interventional echocardiologists, because without good imaging, all of these procedures, like the previous talker was saying, it's just impossible. It just makes things very difficult. What I mean by this slide is when you start in your group and you have your echocardiologist relearning the inclusion-exclusion criteria, it's important to really make sure that that is done appropriately in your group as well, because all of a sudden you get, you refer your patients to maybe a pre-op TEE and they say it's not appropriate, but if they didn't really look at these guidelines, they may have not done the right measurement. So make sure that this is done appropriately, and Richard, for example, in our group is doing an amazingly good job in actually teaching what the guidelines are, what we're looking for. And then in the first implant days, I would suggest, you can do more obviously, but try to do many in the first days, because then your experience really grows. Just don't do one every month. So if you can and you have a lot of patients, do this. Again, gain experience together, then maybe separate out the EP and IC group. We do one a month now. We have so many patients, we do two a month, and probably, hopefully, we can do many more days a month, but definitely try to do it on a very regular basis. And then this would be my question here: how can we deviate from this protocol? Obviously, this is what the protocol is, and we have to follow the protocol if we follow the guidelines. And I have a red light, so I'm just going to show this. And I know that one of the panelists here has similar data. So this was just published in Eurointervention, and it's kind of interesting and provoking because they basically looked at an experience in Europe. And as you can see, whether or not you used NOACs versus VAF warfarin, if you did nothing, dual antiplatelet, single, I mean, the outcomes were actually not that bad. Obviously, this is not randomized, and we're looking at other data, but I think it's provoking, and that poses the question: if you have a patient who's bleeding on warfarin, needs warfarin, can you do this procedure? And even now, do we really have to wait until we have American data? Thank you.
Thank you very much, Mario. Maybe a quick question for you here. You've alluded to, combined effort between EP and IC. Do you recommend that for all programs starting this in the United States?
Well, I had the luxury to, be trained in an academic center, be in a private practice, then come back to a mixture of academic and private practice. And I know that even if I now say it would be nice to work together, then in some centers you will have, and it's not going to work, right? Because these two groups may not work together, and each of them is RVU based, and they don't want to work together. But I think if you can, I absolutely agree with the previous speakers. There's so much experience that the EP folks have in transeptals imaging, working in the LA space, and we as structural interventionists, we have that experience too with MitraClip and all kinds of things, but I really enjoy working with, for example, Raid in our group, where we can just share experiences and do it together.
Just one more comment before we go to DJ here, and that is you alluded to the question about contraindicated patients and not able to tolerate oral anticoagulation. I'll just highlight again, Dr. Holmes at the back of the room here, the AFIB2 study is currently ongoing, randomizing patients who are contraindicated. So if you do think patients can't tolerate anticoagulation post, they should be considered for that. The therapy post in AFIB2 for out the Watchman is depth for 3 months. DJ, you have a question?
EP-IC imaging collaboration. I think I would probably try to push this more on a heart team approach so that there is actually a greater level of collaboration and an appropriate selection of patients and better access to care delivery. All of those are factors that go into the mix. So I think if somebody is starting a program, it's probably much better to forge an alliance and a relationship the way we have done that with the surgeons in the structural space.
That's a very good point. Thank you, DJ, and thanks, Mario.